So hello. We are here at the EMA meeting, the 15th EMA meeting here in Vienna. My name is Heinz Ludwig. I'm a medical oncologist, hematologist, working at the Wilhelminen Cancer Hospital in Vienna. And my partner here is Professor Niels van der Donk. He is member of the Free University Medical Faculty of Amsterdam.
So we now discussed various immunotherapeutic approaches, some more advanced, some we have to learn much more about, and these trials have just started. But I think we should also not forget that various very interesting non-immunotherapeutic drugs are becoming available and have shown very interesting data in recent publications and recent presentations at big conferences. And Heinz, in your excellent presentation on relapse refractory multiple myeloma, how do you envision these non-immunotherapeutic approaches? Which ones are the most promising?
I think there are several drugs which are promising, but I think I would like to mention two which are more advanced in clinical development. And one is selinexor, which is an inhibitor of XPO, which is a transport vehicle or protein. And so there is an interesting phenomenon that many proteins which are produced in the nucleus have to be transported outside the nucleus. And if you inhibit this process, you change the entire genetic machinery and you may induce apoptosis or reduce proliferation of your tumor cell. So, and there is this selinexor, which is a drug which inhibits this protein transport from nucleus to the cytoplasm. And when you administer this drug as a single agent to relapse refractory myeloma patients, you obtain a response rate of about 20%, 21%. The problem is that it is still a little bit, has some side effects. And patients complain a little bit about fatigue, sometimes nausea. But I think this, in light of the high response rate in heavily refractory patients, the drug will be approved in its present form. And the study which is ongoing is a STORM trial. And that will be the basis for approval, in my opinion, in the US. Selinexor is already tested in combination with bortezomib dex, giving, of course, higher response rates. And that will be, of course, that is also of high interest. And they will have a randomized trial comparing Velcade dexamethasone plus minus selinexor. But I think what is important is the company has another drug on file, which does not penetrate in the spinal fluid, and which obviously has not these side effects regarding fatigue or nausea and so on. So we have to wait. I would like to answer in your way. We have to wait for more data, but at this point of time, it's very fascinating, and I think there's good reason to be hopeful. But I would like to ask you, what is your opinion about venetoclax in myeloma?
Venetoclax is also a very promising new compound. Yeah. It is a BCL2 inhibitor, which is already approved for the treatment of patients with chronic lymphocytic leukemia. So it inhibits BCL2, and as a single agent, it has activity in multiple myeloma. And the interesting thing is that it's especially active in patients with translocation 11-14, because these patients, the tumor cells from these patients, are much more dependent on BCL2, and so much more susceptible towards venetoclax-induced apoptosis. The interesting thing is that when you combine venetoclax with a proteasome inhibitor, and you also downregulate MCL1, which is a BCL2 family protein, which is also anti-apoptotic. So when you combine a BCL2 inhibitor with an MCL1 inhibitor, like bortezomib, then you get very high response rates, which also look very promising. And that's why the company has already started another phase 3 trial evaluating bordex versus bordex plus venetoclax. So I think, that will also be a good combination for our patients.
Yeah. So I think the future for myeloma patients is bright. There are thousands of people working on new drugs, on finding important pathways which which would be ideal targets for inhibitors, particularly in the high-risk patients. Do you have any, let's say, thought about what could be helpful in those patients with this high-risk genetic profile at the time being?
Now, when a patient is presenting with very high-risk disease, we do not have access to antibodies, because I think this patient group will really benefit from antibody-based therapies, because in the monotherapy trials and also in the daratumumab, Lendex and Bordex trials, there was clear benefit also in the high-risk group. So I hope that we rapidly can introduce antibodies into the treatment of these patients. But as of now, I think we need to treat these patients with a PI-IMiD combination. Younger patients will benefit maybe from double transplant instead of single autologous stem cell transplant. And I think we need to give our high-risk patients also consolidation and maintenance to really get them into a complete response and then a sustained complete response. And I think also the non-transplant eligible patients with high-risk disease will benefit from a IMiD-PI combination in the future from incorporation of an antibody in their induction and consolidation maintenance.
Yeah.
Do you have other ideas about this, Heinz?
No, not at the time being, but we have to find out the important networks which really drive these high-risk cells, and then we have to find inhibitors for different proteins, and probably we'll be able to slow it down. That is one approach. But the other approach I think I'm dreaming about is that we finally will find a way to reduce the mutational activity of myeloma, because myeloma is exceptional, because it is has such a high mutational activity. So usually they are in the normal genome, they are gatekeepers, or let's say housekeeping genes which control that. They must be out of order because the mutation activity is so high. So if we find ways to keep it down, to control it, so that we don't have to tackle with 100 different clones in one patient in the course of his disease, that would help us to find good therapies.
To prevent the clonal heterogeneity from going on and making resistant clones.
But we're already here speculating about the future. But I think the positive impression we had during the meeting is that the myeloma community has now a very positive attitude. We're seeing all these advances, learning from our basic scientists and seeing the new drugs coming into clinic. So I think it's very good times for myeloma patients, but also for myeloma clinicians.
Yeah, and we see that already reflected, of course, in the survival curves, which are continuing to improve. So I think that's really good news.